welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
I'll be presenting antipsychotics and QTC interval during delirium in the ICU. This is a secondary analysis of the MIND USA trial published recently. For this study, we want to determine whether antipsychotics increase QTC interval in patients with delirium in ICU. We want to investigate the effects of these antipsychotics on QTC in critically ill patients with delirium. We also want to observe the impact of sex on QTC prolongation and see whether or not QTC prolongation is associated with fatal cardiac events. We'll go into background, study design, and discussion. Delirium is characterized by inattention and cognitive disturbances. This is an acute neuropsychiatric condition, and antipsychotics are commonly used to treat so-called delirium. There are non-modifiable and modifiable risk factors. Both are different, and current literature failed to demonstrate use of antipsychotics in either preventing or treating delirium in the ICU. In a worldwide survey, as stated by the pre-test assessment, patients with delirium are treated with typical at 65% and atypical at 53% for antipsychotics. So they're on a majority of antipsychotics for having delirium. In terms of the 2018 PADIS guidelines for delirium, they actually don't have strong recommendations for pharmacologic use. In fact, the only true recommendation that they have is using dexmedetomidine for delirium in mechanically ventilated patients where agitation precludes waning and extubation. We mainly want to use or focus on non-pharmacologic means, which is to avoid bright light and to use a multi-component non-pharmacologic strategy to reduce modifiable risk factors. Intensive care delirium screening checklist and CAM-ICU are the main delirium validated assessment tools we use to assess whether or not a patient has delirium. ICDSC is a totality of different characteristics that if you score more than 3, then a patient is said to have delirium. For CAM-ICU, this is a pathway of questions that ultimately lead to you characterizing if a patient is CAM-ICU positive. If they are, then delirium then is present. Current practices for monitoring QTC is every 8 to 12 hours after initiation, increase in dose, and following overdose of QTC prolonging medications. There are well-described differences between sexes for baseline QTC intervals, and it's unclear whether or not these antipsychotic medications pose same risks of clinically significant QTC prolongation among patients in the ICU. You can kind of see by this graph to the right. While this isn't studied in ICU, you can see that all these antipsychotics have different impacts on QTC prolongation. Lorazepam being the less QTC prolonging medication, while amisulpride is the one with the most prolonging effect. The MIND USA study, which the secondary analysis was based off of, was using haloperidol and ziprasidone to see whether or not it improved days alive without delirium or coma compared to placebo in critically ill patients with either hypoactive or hyperactive delirium. This was a multi-center study, phase 3, and the bottom line of the study basically said there was no difference compared to placebo in all retrospects for primary and secondary endpoints. The secondary or a priori analysis was aimed to determine whether these antipsychotics, the same one, increase QTC interval in patients with delirium in the ICU setting. Again, it's the same concept of a multi-center double-blind randomized control study with the same study period. Patients were randomized 1:1:1 to IV Haldol, max at 20 milligrams daily, IV Geodin, max at 40 milligrams daily, or saline placebo, and they were all administered twice daily. In terms of assessing whether or not patients had delirium, they used CAM-ICU. They included patients with a baseline QTC interval obtained after delirium being less than 550 milliseconds. They either had a subsequent QTC also measured within 5 days of informed consent. They were admitted to either medical, surgical, ICU admission. They were either on non-invasive positive pressure ventilation or mechanical ventilation, and they were CAM-ICU positive. The reason why they used 550 milliseconds as a cutoff was because they originally did 500 as all the other QTC studies did. However, an interim analysis showed that the most that these medications prolonged the QTC was around 7-ish milliseconds. So they actually received FDA approval to increase this cutoff to 550 milliseconds. For exclusions, they excluded patients with a baseline severe cognitive impairment, high risk for medication adverse effects such as pregnancy, breastfeeding, TDP history, QTC prolongation, and a history of neuroleptic malignant syndrome. They had a moribund state, they had pre-existing antipsychotic treatment, allergies, resolving status, follow-up barriers, and if the patients were incarcerated. They used multivariable proportional odds logistic regression for statistical analysis. They analyzed a total of 20,000 patients and finally included 566 patients after a list of screening for exclusions were met. They divided this again 1:1:1 to Haldol, Geodin, and placebo. The first dose of the study medication was administered after delirium was diagnosed. They were randomized and a bedside QTC screening was taken. QTC was measured within 10 to 30 minutes following the first study medication, and if 1 or more hour elapsed between baseline 12-lead and study drug initiation, bedside telemetry was taken to confirm whether or not this cutoff was less than 550 milliseconds. Based on the reading, the volume and dose was either doubled or halved or even held at the 12-hour interval. Here are the endpoints. For primary, they focus on median change in QTC interval. Secondary included maximum pre-dose QTC interval, correlation between bedside telemetry and 12-lead ECG measurements, sex association, and incidence of ventricular arrhythmias. Exploratory outcomes was daily pre-dose QTC interval across all days, post-dose QTC interval, and association of any patient factors that are related to initial post-dose QTC interval changes. The average age for this population was around 60 years old, 57% being male, and comorbidities were common and severity was generally pretty high. For diagnosis at admission, more patients in ziprasidone were present with an admission of surgery, COPD, asthma, as well as other, which includes gastrointestinal bleed, kidney failure, hemorrhagic shock, metabolic, endocrine, electrolyte disorder, and so forth. Notably, that answers something of the secondary endpoint is the incidence of ventricular arrhythmia and TDP. As evident by this table, there are more cases in the Haldol versus ziprasidone group versus placebo, which are all zeros. So you can see that while a bit more cases occurred in the Haldol and ziprasidone group, they weren't significantly high enough compared to placebo at 0. There are also recordings of participants with doses held certain intervals. So participants with doses held was a total of 43 patients, and the majority of them were in the ziprasidone group. The number of doses held was counted to be 84, and half of them were from the ziprasidone group as well. Next dose also held for QTC was also majority in the Geodin group, and discontinuation last dose, again, the majority of them were in the ziprasidone group, though Haldol also had 3 patients, while placebo was at 0. In terms of median change in QTC intervals between days 1 and 2, there were no significant differences between placebo, Haldol, and ziprasidone. There's also no notable sex differences in QTC interval changes of male versus female evident by the placebo, Haldol, and Geodin group. The median exposure to the study medications was around 4 days, the interval quartile range being 3 to 7 days. They also looked at the baseline characteristics as you see in the table here. For age enrollment, sex, BMI, and SOFA score at randomizations, you can see not really a significant change evidenced by this forest line plot. Even for treatment of Haldol versus placebo and ziprasidone versus placebo, there was also no notable difference. For the maximum pre-dose QTC interval on study day 2 and the distribution of initial post-dose QTC interval, there was no noticeable differences as evidenced by this box and whiskers plot. While the ziprasidone group had a couple stragglers up in the 600s, there are only 2 of them, and you can see the majority of the distribution is pretty similar to the Haldol and the placebo group in all 3. What I liked about this study is that they also correlated 12-lead ECG and telemetry QTC interval readings. you can see that they found out that there was a pretty strong correlation in between the two different readings, evidenced by a rho of 0.53 and a p-value of less than 0.001. The reason why they did this is because if the cutoff was less than 550 milliseconds, they took a bedside telemetry to confirm. And then if it truly was, then they took a 12-lead ECG to fully confirm that the patient had a high QTC interval reading. They found that 12-lead ECG measurements were generally a bit lower than the telemetry QTC readings, but they correlated well with each other. There are no strong evidence that either medications can be associated with clinically relevant QTC interval changes or even ventricular arrhythmia in critically ill patients with delirium. There are no clinically or even statistically differences in the QTC interval changes with these study medications. Surprisingly, there is also no association of sex on the relationship between these antipsychotics and QTC interval, despite prior literature suggesting there is. And of course, a moderate correlation was found between the two telemetry and ECG measured QTC intervals. And this suggests maybe a standardization in these two measuring modalities. What this study did pretty well was that this was a large, multi-center, randomized clinical trial. There are no evidence of any clinical or statistical significance in a very large population. They used an FDA-approved QTC interval threshold cutoff, which is higher than many other literature pieces studying the impact of QTC. And last but not least, this was a pragmatic design that included a large, diverse study with common electrolyte abnormalities and many concomitant QTC prolonging ICU medications that's pretty reflective of an accurate ICU population that we see in practice. Limitations, however, there was no record or sub-analysis for the patients taking these concomitant QTC prolonging medications with electrolyte abnormalities. They also used only one standardization for QTC interval, being Bazet's, and there was also no standardized ECG equipments between all the centers involved in the study. Something to note is that ziprasidone is also not a common antipsychotic used in the setting of ICU delirium. And doses did not match any case studies that had a much higher QTC interval cutoff associated with sudden cardiac death. There was also a lack of correction for atrial fibrillation or bundle branch block, nor did they actually record those arrhythmias. It's actually unknown whether QTC prolongation in the presence of bundle branch blocks increases the risk of arrhythmias. And last but not least, they had a pretty short duration of testing these antipsychotic medications. Something to add is that I also wish that they studied more antipsychotic medications instead of just two. As a conclusion, neither Haldol or Geodin was associated with significantly increased QTC prolongation compared to placebo. There's a moderate correlation between these two measured modalities, and in lower-risk patients for QTC prolongation, frequency of QTC monitoring should be re-examined. That's a conclusion to my study. Here are the references. And let me know if you have any questions through my email. Thank you so much for your time.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.